Can I ask, are we ready to start? Мы готовы? Yeah, would you be so kind as to please move to the front? Because we're a smaller group. Might feel a little bit more collegial and be more conducive to discussion, and we don't bite. Well, good morning, everyone. My name is Philip Lafleur. I'm one of the co-moderators of this session. I'm from Toronto, Canada, but I've lived here in Astana for 6 years, and I'm now based at the Nazarbayev University School of Medicine, which is just right in the backyard of Dr. Pia's hospital, Dr. Pia and colleagues. We are an English language medical school. And Nazarbayev University is an English language school here in Astana, working in the medical sphere in Central Asia. So I'm excuse me, I'm glad to be here today. I think we have a very interesting and diverse list of topics to think about together. I ask you to please be participative, please ask questions, please challenge the speakers, and I hope you enjoy this session and learn something that's useful for your own thinking and practice. I want to invite Dr. Paul Sargent, who will be our first speaker. He is from the Gasthuisberg University Hospital in Leuven in Belgium.
Mrs. Chairwoman, Mr. Chairman, can I have the first slide on, please? I'm sorry? I don't understand.
Sargent.
Sergeant.
Sargent.
Like in Beatles, Sergeant Pepper's Lonely Hearts Club Band. I downloaded it 2 days ago. I gave it here. Yes. Yes. That's fine. Shall we go ahead? Sure. Good morning. It's a difficult subject, scoring systems. And one of the questions is, can we trust them? And do we really know sufficient statistics to understand the scoring systems? I've been interested in scoring systems since 1967, not 1867, but 1967. Indeed, complex scoring systems can be trusted. What you see here on this plot is a survival curve over 66 months of an independent population. An independent sample of 3,700 patients with 5-year follow-up. They were tested using a very complex mathematical model based on the supercomputer modeling of a sample of 5,880. It's Eugene Blackstone who helped me with this analysis. And as you can see, the dotted line is the observed survival of this population, and the straight line is the predicted survival with the uncertainty. And as you can see, under certain circumstances, which I will not go into at this moment in time, it is perfectly possible to predict. For example, in the patients with single vessel disease, we predicted that 13 patients would die and 8 patients died. On the patient with two vessel disease, 56 died, and we had predicted 53 died. And we had predicted 56, and 122 and 125 for triple vessel disease. So our prediction system is very good on the long run if you are able, if you have enough data modeling, and if you have a very strong mathematical model to do that. To create this plot took 15 years of my life, so it's not something that is done in a few minutes. In a scoring system, we want to predict the future for a certain patient or for a group of patients. And in fact, the problem with patients, luckily so, is that most of the events are rare events. And there are different methods. I'm not going to go into detail. If you want to copy the reference, you can go into more detail. But there's many methods to predict the future of a patient. You can sit down with some experts, you can do market prediction, you can do scenario planning, or you can do statistical forecasting. When we use a scoring system, we believe that we're doing statistical forecasting. But there is a number of problems, and as you can see on the second column, inappropriate reference class. It all depends on which database these scoring systems have been based on. The problem with simple scoring systems is that they replace a time-related event, survival in the future, into a non-time-related event. And this has consequences. We have to understand that. What's the first problem? Well, simple scoring systems do not include the correct patients. As an example, the non-operated patient is never audited. What you see in this plot is a couple hundred patients operated in cardiac massage before surgery, at the time of surgery. And as you can see, we lose of these patients 40% of them in the early, but 15 years later, at least or close to half of them are still alive. These are never included in scoring systems. So that's where it already starts. Scoring systems only include a very limited number of patients. And the whole problem is, what is time zero? Now, time zero is a concept that is difficult to understand, but it is very important. When you look on the tide, the water coming into the beach, you can see that the same beach, the tide has different lengths, and the coast has also different lengths. I give you an example here. In none of the scoring systems, the waiting list for the waiting list mortality is included. And I show you my own mortality on the waiting list. I'm very astonished. It's never reported in the literature. But what you see on the left side is the mortality on the waiting list. And you can see that in, for example, 2004 on the left side, the mortality was up to 1% on my waiting list. And what was in 2004 the average waiting time? It was 20 days. So the mortality on the waiting list is never included in the scoring systems, and we forget that, so the time zero. So how should we make a correct scoring system? We must start observing the interval at the time the patient is discussed. That's the time of the multidisciplinary decision. That is time zero, not the moment the patient comes into the hospital or the moment the patient enters the operating theater. Time zero of any reporting of quality and any scoring system should be the day of the multidisciplinary decision. So what is then the time end? When should the scoring system stop evaluating? Of course not the hospital survival. Who cares about the patient leaving the hospital alive? We treat patients not to survive the hospital. We treat patients to be good in 5 years' time, in 10 years' time, in 20 years' time. So we have to understand that. And it's a catastrophe. Cardiac surgery, I just had a discussion with a young girl about cardiac surgery. Cardiac surgery is a catastrophe. We do not do follow-up of our patients. 99.9% of the units have no structured follow-up of the surgery they do. And we should do that. I have operated myself close to 20,000 patients in my life, and I have published complete follow-up of all the patients, not just for survival, but for a whole number of events. We must understand that the minimum observation interval will depend from the pathology, the therapeutic alternative, and the risk domain. I forgot that I am translated, so I'll speak a little bit slower for the girls. So should we monitor hospital events? Absolutely not. Should we monitor 30-day events? It's a stupid day. Why would it be important if a patient dies day 29 and not important when he dies day 31? That makes no sense. The 30-day interval comes from the time when a patient, there was no intensive care, and I have been in that episode in the 1970s. There was no intensive care, so if a patient was going to die, he was going to die in the first hours. 30 days was very long. Today, you can put a patient in intensive care for 30 days on an ECMO and dialysis, and he survives the 30 days. So you must at least, if the scoring system is going to evaluate the risk of care, you must have the correct interval. As a typical example for coronary surgery, coronary bypass patients continue to die at least for 3 months and up to 6 months after the procedure. What you see here is 4 different observation intervals. So you can see on the left side, if you want to evaluate stroke after coronary surgery, the hazard function is down at day 15. If you want to observe an interval of an infarct, the hazard function is down at day 5. And return of angina, you have to go up to 18 months. So the 30-day interval is absolutely not based on any scientific evidence. Once you start looking into the details of hazard function, you can really observe different variations, much more into detail. You see here 2 stroke evaluations and hazard functions for stroke after different approaches in coronary surgery. And you can see that, in fact, the interval is getting totally different for different approaches. And now you can start working on reducing these intervals. So what's the problem? We don't do follow-up. So can you imagine, it's like flying passengers from Frankfurt to Astana and only worrying that they step into the plane, and you don't worry if the passengers arrive in Astana. It is absurd, but that is what cardiac surgery is today worldwide, even in the largest centers. So how do we do follow-up? Well, follow-up is something that I had the privilege of being learned by John Kirkland and Blackstone. There's 2 methods. There's the informal method, which is the date of the last report, and then there are the formal methods. We should not use an informal method. When I read a manuscript, the first thing I read is not the abstract, is not even the title. I go to methods, and I want to see how is the follow-up structured. I want to see 2 words, either the anniversary method, which is an observation interval at the anniversary of the date of entry into the study, or I want to see the common closing date method. Follow-up methodologies is a very complex method. We've published this many, many years ago in the Annals of Thoracic Surgery. It was called Closing the Loop. We must understand that if we contact a patient, the first feedback will not be 100% complete. We will probably have 40% of the information when we contact the first time. At the second contact, we will maybe reach again 40%, and gradually we are going to reach more and more until we have 99.9% complete follow-up. Indeed, if you are going to construct a Kaplan-Meier curve or any other of the other survival curves, and certainly if you're going to do multivariate analysis of them, you need to understand the concept of censoring. I don't know if I have a pointer. No, I have a pointer. Yes, I have a pointer here. No? Yes, here. There's a pointer here. And as you can see, there's a word here it's called sensory. You have to understand the concept of sensura. It's a little bit too difficult to explain in this presentation. It has something to do with the Bible, with the New Testament and the Middle Ages of the censura. But it's an important concept to be able to construct these survival curves. But some countries have done very well. Under my guidance, the Swedish country have been able, for example, to plot one at the national level to really create these plots. I hear very often, and when I do a review of a manuscript, and in fact this morning at 2 o'clock I did a review of a manuscript using the Euroscore 2 as a scoring system to correct. The person who uses this scoring system has never read the manuscript. Because if you would have read the manuscript of the Euroscore 2, you would have seen that they missed 50% of the patients at 3 months. So the Euroscore 2 is a totally unacceptable scoring system because the follow-up was catastrophically incomplete. If you talked with John Kirkland and you came up with a follow-up and he would ask how complete is it, he wanted it to be at least 99.7% before he even started talking to you. So nobody has read this, but this is a block of text coming straight from the manuscript, and it says more than 50% of the patients are missing. Even at 30 days, they're missing 50% of the patients. How can you build a scoring system when you're missing 50% of the patients? Additionally, simple scoring systems score medical decisions and not event. A medical decision is a biased component. It could be okay, it could be a correct decision, but it's biased. It's not an event. Simple scoring systems carry variables we have, but not the variables we should use. Because a patient is, of course, today, when I started cardiac surgery, the patients were perfectly healthy. Their only problem was their heart. But today we are treating patients who are 80 years old with bad kidneys, bad lungs, bad physical reserves, a history of oncology, very complex, maybe mental reserves very restricted. So we have to understand that if we want to score the risk for this patient, we have to take that into account. A typical example, some people then come up with funnel plots. Brilliant. It looks very brilliant. And if you're on this side of the funnel plot, it looks perfect for you. And if you're on that side, it looks catastrophic. But what happens is you have to go deeper into the project. This is a scoring system used in the ProCare project on gastrointestinal surgery. It's not so important. But as you can see, it uses only nominal variables. So yes, no variables. It can never be a refined tune for a scoring system. My very good friend, Mr. Ranucci, came up, Marco Ranucci from San Donato in Milan, came up with the ASEF score. And what he showed is that if you use only 3 variables, renal function, ejection fraction, and age, you had a very good scoring system. And I challenged, as a reviewer, I challenged Marco, and I said to Marco, I said, just a second, did I miss that plot? Yes. And then I'll come back. And I said to Marco, Marco, that's fine that you have this scoring system, but what I want to know is how accurate is your scoring system? And scoring systems should come up with sensitivities, specificities, area under the curve, but even more important is the PPV, the positive predictive value. The positive predictive value is the correctness of predicting that it will rain tomorrow in Astana. How accurate is the scoring system? The positive predictive value is the value that the patient will die from the procedure. And I want you to see here that the scoring systems only predict in 8%, 6% of the cases the correct prediction of mortality. So it's catastrophic. 93% of the time they are wrong. 6%. You would not want your life to be decided on a scoring system that is 93% of the time wrong. Why do we use them? Because we don't know the mathematics around it. So let me go back a few slides to where we were. As you know, when you start shooting, there is a number of evaluations. Perfect accuracy and prediction, fair accuracy, fair precision. So it's very important to understand these mechanisms. When I used the Euroscore on one of our own data sets, I had an ROC, or an area under the curve, of 0.77. In the literature, they would say, oh, it's very good. It's catastrophic because the scoring system predicted on the pivotal value 877 patients would have died, and they did not die in our hospital. So the scoring system Euroscore was wrong in 877 patients on a population of 4,800. But we still use it. We still use Euroscore all the time. And please look here that the other scoring systems, the Cleveland Clinic, the Logistic Euroscore, the Northern, the Personet, the ASEF score, do similarly bad. So none of these simple scoring systems has really any values. Recalibrating something also makes no sense, because when the scoring system is bad, if you refine it a little bit, it still stays bad because the fundamentals on which it has been based, the mathematics, is not correct. But it's a catastrophe because simple scoring systems, oh, excuse me, I have to go back. Simple scoring systems lead to catastrophes. I'm an expert for court, and I can tell you that today in newspapers in Europe, you can find evaluations of hospitals, evaluations of individual surgeons with their mortality presented. As if, first of all, the surgeon is the only one responsible, the anesthesiologist, the cardiologist, the intensive care physician, the nurses who have made mistakes, they're not taken into account. It's all put on the back of the surgeon, and then in addition, bad mathematics are used. The consequence is this kind of listing, like die große Ärzteliste, where you list the mortalities of surgeons, and I can tell you each time it has been a catastrophe, but I have been there in court in many countries defending the surgeons, and up to now I have won every single case, and they have paid the surgeons because your career is gone. I can tell you, for example, this here, top heart surgeon, top heart hospital under investigation, this surgeon, a very good friend of mine, I consider himself the best surgeon of the United Kingdom. His career was stopped at 60 years of age by his own hospital. They said, oh, sir, your results are not that good in this plot. I think you'd better stop. And he stopped operating patients just because a bad plot identified him as a bad surgeon, which absolutely is not. I think he's the best. He would be one of the few surgeons that would operate me. So it leads to catastrophes and leads very often to court. So I want to warn you, when you see the word risk-adjusted needs to comply with the laws of statistics. It needs to have the R-square. It needs to have a good AUC. It needs to have the correct PPV, negative predictive value, positive predictive value. It is very important before we accept scoring systems, Mr. Chairman, and I thank you for the privilege of the floor.
So we've heard from Dr. Sargent the need for complete follow-up when we're thinking about developing scoring systems. We've heard a little bit about the need for accurate timing of when the data collection starts. And he concluded the conversation by talking about not only understanding the reliability and validity of the scoring systems and the data that we're using, but also the very significant implications on the careers of some of our colleagues. I want to open it up for questions. Please don't be shy. Does anyone have any questions? Dr. Sargent will also have a second presentation in a moment, but let's just pause for a minute. Oh, they've both been, okay, so he's put both of his presentations into one, so that was the full presentation. So are there any questions? I have one. Dr. Sargent, in working a little bit with our cardiac surgeon colleagues and interventional cardiologists here, I've learned that they do actually quite fastidiously collect data on their patients. In working with some of our colleagues to try and publish these data, it's been a challenge because the numbers are quite small. Do you have any suggestions for our Central Asian colleagues for how they can use data to contribute to meaningful scoring systems and risk prediction?
Yes, anybody who starts today with a data collecting system, the first thing they should do is collect them correctly and change the existing dysfunction of the systems, because that's the best way to challenge the existing systems who are badly used. The number of patients is, of course, important, and I have been lucky in my life that I worked in a high-volume institute. My own number of patients every year was around 600. I operated myself around 600 patients a year, and in the institute it was 1,800 every year. Now, of course, that is huge numbers. But understand that if you bring together a project, for example, I know in Astana, in Kazakhstan, they want to bring the 22 cardiac surgical centers together. You create another mathematical problem, is the variability between the centers. In the beginning, I wouldn't worry too much about the variability in the centers. The first thing a scoring system starts is correct collection. So start documenting at the time of the multidisciplinary decision and decide for an interval that is far enough in follow-up, at least 6 months and preferably at least 1 year or 2 years in follow-up. When you have that, start collecting the appropriate data in the appropriate format. As an example, weight is in kilograms with 1 decimal. Age is the exact date of birth, not categories, not nominal variables, yes, no. As an example, pulmonary function. In our database, we have 8 variables describing the pulmonary function. We have something about histories of pulmonary disease. For example, a history of tuberculosis, a history of pneumonia, which has a major impact on the patients, but also the vital capacity, the 1-second value, numerical values, so that you can describe your same variability, the pulmonary variability, in different formats. And you will see that in one mathematical model, it will be the 1-second value that is important, and in another model, it will be the history of pneumonia. A patient, for example, who has had a history of a severe pneumonia has a major impact. So once you start describing these variables in the correct format, I wouldn't worry too much about the variability between the units, as long as the data collection is going okay. Because what you want in a quality control over a country, for example, in Kazakhstan, you don't want to identify the best unit. I don't care about the best unit, because the best is exactly as you say, it has confidence intervals. So I would absolutely never go about it. What you want to do, you want to identify the lower outlier. And in the lower outlier, that does not mean it's a bad unit. It's just a mathematical outlier, because then you have to go and try to find out why it is an outlier. Because some patients, you can never correct the variability. Let me finalize with one typical example. I have operated a patient, for example, after lung transplantation. The patient is undergoing a lung transplantation and they see ST segments, ST segment changes. So they worry. They finalize the lung transplantation, they go to the cath lab, they see a left main disease which they missed and a number of issues, and they say, we're going to do surgery. So the patient comes back, goes back on the pump, and receives coronary surgery. This is a very high-risk patient. Should you do him? Of course you should do him. But you cannot correct this variability in a number because it's a rare patient. And so this is what you have to do then at the later end. So I would not worry about identifying the best. I don't care about the best. I would try to identify the negative outliers, not call them bad, but just call them a mathematical outlier and try to upgrade that information.
Thank you. Are there any other questions? Okay, thank you, Dr. Sargent, for an engaging presentation. Our next presentation actually fits quite well with some of the topics that Dr. Sargent addressed. Dr. Tanya Melnick is from the University of Minnesota in the USA. She's a co-chair of this session as well, and she's going to talk to us today about clinical errors in medical practice.
Good morning, everybody. Everybody can hear me? So just to segue into the talk, as you probably know, a lot of medical errors start with issues in communication. And my presentation is actually a demonstration of that, because when I talked to the organizing committee, we talked about what it will be the topic of my presentation. And I said, I want to talk about medical errors and disclosure. So it came out as medical errors in clinical practice. So miscommunication here. As a result, we're having a slightly different presentation. What I want to talk about today is talk a little bit about how common medical errors are and what they result in, and talk about different approaches to error disclosure, which is an important part. Medical errors have very different definition depending on who you listen to. There is a legal definition that will vary from country to country. It will also vary between what clinicians perceive as medical error, what patients perceive as medical errors. But Joint Commission and Joint Commission International, which some centers actually are working with on their accreditation, define medical error as any unintended act, either of omission, meaning you didn't do something that you were supposed to, or commission, meaning you did something that you weren't supposed to do, or any act that does not achieve its intended outcome. And intended outcome, we usually do something because we plan for the patient to achieve a certain result. When it doesn't go as planned, we have an unintended outcome. Worst example is obviously patient death. And how do you deal with something where your patient died and you know something did not go right, but you don't know what and you don't know why. So this is a patient I was seeing recently, and for some of you that may or may not be relevant, but this was a 73-year-old patient I've been following for an extended period of time, several years. She had very extensive smoking history, but quit 15 years ago. And she had lymph node biopsy of her neck 18 months ago. Family history, no cancer, no pulmonary symptoms. She wasn't coughing. She had no shortness of breath. She had completely normal physical exam. But the result of the biopsy 18 months ago, this time, of the mass actually showed moderately differentiated adenocarcinoma of the lung. What was the problem with that? Oh, doesn't want to advance. Can I have the next slide, please? So this was her CT at the time prior to the biopsy. She obviously has a significant mass. We did not know at the time whether or not she actually had spread of her cancer. And I talked to her about the results because they were not available at the time of her hospital discharge, and kind of the plan of what to do next. So next was sending her to see oncology. And the oncologist reviewed all of her imaging, including the one that was done outside of our system. And it turns out that when she had the biopsy of the neck mass, she had a CT prior to that, and that CT 18 months ago already had a mass in the lung, which radiologists did not comment on. They were focusing on the neck mass and they missed the one that was in the lung. So what do you do for that patient? Your choices are to say nothing. She has to deal with cancer, that's enough already. She doesn't need to know what happened to her and that the diagnosis was actually missed 18 months ago. You mentioned it briefly. You advise patient that it's very unlikely that the cancer has spread in 18 months, which may or may not be the truth. You can talk about the misdiagnosis, and you can blame the radiologist. Hey, they missed it. Or you can talk about the misdiagnosis. You can apologize for the error. And you can promise her a very thorough review of why it happened, and potentially things you will put in place to prevent that from happening to another patient. She wants to know what it means for her. She wants to know what it means for other patients. And we say often that success is a team sport. You need a good team for patients to do well. You need a good team to do well in competition. But failure is also, and very often, is a team sport. When we fail, it's because the entire team, the entire system failed. Something did not go well. And it's rarely just one person's fault. So errors are exceedingly common. Oh, can we go back, please? Thank you. It is considered to be a third leading cause of death in the United States. More people die of medical errors than there are people who are dying of breast cancer and traffic accidents and actually HIV-related disease combined in any given year. Obviously, it's a big concern for us, clinicians. It's a huge concern for healthcare system because healthcare systems know something is not going right within it, and it's also concern for reputation. Patients don't want to go to the hospital where patients die. Why would you do that? No good reason. You can go to another hospital where nobody dies. I don't know of any hospital that actually has that. And many providers are not prepared to talk to their patients about what happened to them. So we're going to do a very quick preparedness test. We'll go forward. If I can ask you to stand up. There you go. Great. Thank you. And if I tell you right now that we are having a zombie invasion and you need to leave the room very quickly, where would you go? Orient yourself to the room. Show me where would you go. Can you show it to me? Yeah, just point to where you go. Okay, how long did it take you? A few seconds. Well, we're a little bit in danger here because doors and exits are not clearly marked, so it will take you a while. It's a safety risk, actually. Exits supposed to be clearly marked, and they need to be lighted, and they need to be lighted with emergency lights. Otherwise, you wouldn't know where to go when there is a lot of fog or smoke in the room. So this room has a serious safety risks already built into it. Okay, I want you to think. Just sit down. Sitting down is great for thinking. So think about a medical error that you have been involved with, happened to your friend or family, or you, or actually happened to your colleague. Can everybody can identify or think about the error that happened recently, let's say in the last year? I can. Raise your hand when you're ready, when you know something did not go right. Like a wrong medication given, wrong diagnosis, retained surgical sponge, anything. If you don't know personally of the error, think about the error that could happen within your system. Everybody? Yes? Yeah. Okay. So please stand up. You don't have to leave the room yet. But think about what would you say to a patient if you are his or her physician and you need to talk about that error. Everybody understands what I'm asking you to say? I can repeat it in Russian, if that helps. Yeah? Если вы знаете, если вы думаете об ошибке, которую вы должны объяснить своему пациенту, подумайте о том, что бы вы ему или ей сказали. Okay, you can sit down once you know, no, not yet. You can sit down once you know what is it that you're gonna say. Exact words to that patient. And I want you to stay standing up as you're thinking. Можете сесть, когда вы знаете, что вы скажете этому пациенту. If you don't know, it's okay, we'll talk about it. And we'll talk about why it's difficult. How long did it take you? If it took you a few seconds, that means you are ready. If it took you longer, you're not prepared. You don't know what to do. You're going to be caught. And it will happen to you. It will happen to your patients. I can guarantee you that. Can I have the next slide, please? Thank you. So what happens with a typical system where we deny and defend, and we want to, first of all, defend ourselves, we want to defend our hospitals. What happens is we're going to say, oh, yeah, something didn't go right, but it's not our fault. We're not going to deny that everything was perfect. Well, we know a patient is suffering, but we're going to say, oh, it's not our problem, it's patient's problem. For patients, they want to know what happened, why things didn't go like they were supposed to. They feel abandoned, they feel betrayed. They're very worried about the same thing happening to another patient. They know it will. It happened to them, and it will happen to somebody else. They're feeling obviously very sad. They also feel guilty because they feel that they haven't done something that they were supposed to do. It's their fault that it happened to them. Is it their fault? No. For a clinician, it's anxiety about what the future actually holds. When it happens to a clinician, we worry about making that mistake again. And we worry about making more mistakes. Not necessarily like the one we've done, not necessarily that what just happened, but about mistakes that you may not know about, mistakes you will make in the future, and mistakes that are not evident yet. There's loss of confidence. For a surgeon, that's probably one of the worst things that could happen, that you're not sure of your technical skills in the OR. Sleeping difficulties are common. You lose sleep because the patient has been hurt. Reduced job satisfaction. You come to work, you still have to come to work, but you're so unhappy that you continue to work. You worry about mistakes, so you're not the profession that you have aspired to be for pretty much all your life is no longer bringing you joy. Fear of harm to reputation. As Dr. Surgeon has mentioned, it can destroy physicians' reputation, particularly if it becomes very public. Fear of litigation, and I know for Kazakhstan it's a real concern, and we can talk about it a little bit too. And fear of administrative action. You're going to be put on leave, you're going to be put through mandatory training that physicians often see as demeaning. It's like, I'm fine as a physician, why do I have to do this additional training and additional supervision? Error disclosure does have significant ethical principle behind it. You are obligated by law to consent the patient to to the procedure. You need an agreement of the patient to do something to them. Do surgery, invasive procedure, even prescribing medication involves consent. You talk about the risk of medication, you talk about risk of treatment or no treatment, and once the patient agrees that, yeah, I will do it, or yeah, that sounds like a good idea, let's go ahead and do it, you have patient's consent. It doesn't require a long form to consent patient to take the medication, but for some medications, yes, it does. Chemotherapy is one of the examples. But if you are obligated to disclose the risk of treatment to the patient, you are equally obligated to talk to patient about what happened to them when they sustain harm as a result of treatment. They need to know why it happened, not just what could happen, but why what happened to them actually happened to them. It's very hard to admit the mistake to yourself. It's equally hard, if not harder, to admit it to others, your colleagues, your peers, and your patients. Communication challenges are huge, and it's a different skill set to actually disclose the error to the patient. It's a difficult topic. And those conversations are not common. We're not trained to do them. We talk about consenting patients for procedure every single day. If you are in OR or cath lab every day, you will be consenting patients. It's a conversation that's easy. You know what is it that you're going to say. For medical errors, there's no standard. So how often do you go through training for disclosure of medical errors? Almost never. It does take time. You need to set aside time to prepare to disclose. As I already showed you, you are not ready, so it's going to take time. It's really difficult to do on the spot. And it doesn't happen at one point. You cannot tell the patient that, oh, we're disclosing this error to you, we're done. A lot of times there is a review process to go through to determine if there is an error in fact. And it requires follow-up conversations with patients. And causes of medical errors are, not just sometimes, that's the wrong word, are often very complex. It's rarely a one event that failed. Usually there is a cascade of events that led to the error. And you have to review what happened to really do a thorough disclosure. And it can have a significant effect on your reputation and reputation of the hospital, so that's another concern. So how? When do you need to disclose? As I mentioned, it's a multi-step process, but once you know something happened to the patient, and you know that pretty quickly, you need to start that disclosure process. If the patient ended up in the ICU with a significant complication after what seemed like a routine procedure, and you worry about the patient, you need to start talking to the patient and the family. Do you have to disclose that error happened? No, you don't know it. But you need to disclose that something did not go right as planned. Who should participate in the disclosure? Obviously, it's the patient. If the patient cannot participate in it for a variety of reasons, patient is intubated and sedated in the ICU, or patient is dead, that can happen, then you need to talk to the family. And you need to involve clinical team. And oftentimes, it's the physician. We do have mid-level practitioners. We have clinical practice nurses. We have physician assistants who often see patients in the hospital or in clinic, and they're the team member that was following the patient. So they do need to be involved, as well as their supervising physician. Having a nurse in the room would be helpful. We do recommend having a witness there, and that witness helps to document what was discussed and also is there to provide support for the physician who is disclosing. You need to lay out facts in very, very simple terms. This is not the time to demonstrate your skills in medical language. You're fine. Patients may not get it. So use things and terms that are very simple. CPR, balloon pump, patients don't get it. Fewer abbreviations, descriptive terms rather than, oh, this is a term you use every day. Yeah, it's fine. Yeah, you can continue to use it with your colleagues, not with a patient. Outcome of the event, what happened? Next step in treatment, if there is a patient to treat, obviously. And patients and families need to know that they will be taken care of, that this complication will be treated. You're not going to abandon them. If the patient died, you need to talk about what's going to happen afterwards, what kind of closure you're going to have. And if the review is planned, and often it is, you need to give updates to the family on a scheduled basis. You cannot say that, oh, we'll get back to you on this one. You need to tell them exactly when you're going to get back to them and who will get back to them. What patients want to know? They want to know that the error did occur, which you often cannot give to them before you do the review. They want to know what error was, why it happened, what you're going to do to prevent it from happening to other patients, and they want an apology. They often want an apology even if you've done nothing wrong, but they sustain harm as a result of treatment. Is that apology appropriate? No. That apology is appropriate when indeed you have done something wrong. What's appropriate for cases like that is sympathy. There is a difference between we're sorry we did this to you and we are sorry that happened to you. And that may be difficult to translate into Russian. Do you want me to say it in Russian? Yes. Есть разница между терминами. Мы сожалеем о том, что с вами случилось, и мы просим прощения за то, что с вами случилось. Разница есть? So when is sympathy or we are sorry that happened to you appropriate? With every event. We are sorry that happened to you. We are really sorry. We did not plan this. We wanted you to go out of the hospital alive and well. We're really sorry you're in the ICU. Мы сожалеем о том, что с вами случилось. В любом случае, вне зависимости от того, была ли ошибка или нет. So how do you do that? Again, it's a concern and empathy. Sorry that happened. It's acceptance of responsibility when it's appropriate. And you need to tell the patient who they can call, who they can contact if they have any questions. You do need to be honest and accurate and plan your conversations and definitely document your conversation. We are working on disclosure program at the University of Minnesota, and we do recommend documentation of every discussion with the patient as the disclosure process goes on. What not to do? Do not speculate why it happened. You don't know. What you don't know, you don't know. You can tell the patient and the family that we do not know why it happened to you. We're looking into this. But if they ask you, well, what do you think happened? The answer is you don't know. You may think about what happened and why it happened, but are you ready to talk about it before you have the facts? No, and you shouldn't do it. Do not assign blame, and do not assign blame to yourself. Unless you're pretty certain this is what happened. Do not use medical jargon. Patients don't get it, and they're stressed already, so they're definitely not going to get it. Do not underestimate the verbal conversation. So when you're standing like that, well, we don't know why it happened. It's not going to go well. Everybody needs to have comfortable chairs to sit. It has to be a room that is quiet. You cannot do it in a busy ICU. Take the patient. Well, if you cannot take the patient, take the family to a quiet room, sit everybody down. Make sure you have enough facial tissue. There will be tears. And your body language should express what you feel, which is you feel sorry. Do not rush to bedside and become overly emotional. This is not the time to panic, which is why you need to take time to think about the disclosure. When the physician is hysterical, it's not a good time for that physician to disclose. Do not wait until you know absolutely everything. Update the patient as the review goes on. Update the patient and the family when you know more. And you need to wait for the family and for the patient to be done. And you can usually tell it. They don't have any more questions, and you can ask repeatedly if there are more questions. You can tell when the family's leaving, and they may be done, and they may be leaving very angry. That's okay. That means they're done now. They may not be done quite yet with questioning you, but they're done at that moment. And finally, do not seek sympathy for yourself. Yeah, we feel terrible, and we feel terrible about what happened to you, and the physician is really feeling sorry for himself. You know, that never happened to that person. Wrong approach. Family is at the center of those conversations. Oftentimes, the disclosure process works really well when there is a program in place. When your leadership, when your institution does not support disclosure, that will not go well for you to talk about it with a patient. And some systems don't want you to talk about errors and adverse events to patients. And physicians have been silent about this as a result of it. That does not go well. That results in more litigation and more lawsuits and actually greater compensations. It does not seem to go well in courts when patient says that, you know, nobody talked to me. And that's often what brings patients to court. Nobody's talking to them. That's the only way they see to get information on what happened to them. You need peer support. It's traumatizing for any physician and often for the entire team to go through the medical error. The second victim is a person who has been traumatized, who is a provider, a clinician, who has been traumatized by the adverse event. And I can tell you that I have been there several times. I've cried hysterically when I lost a patient. I blame myself. And I was fortunate enough to have peer support at the time. It took a while to recover. But I can talk about it. And again, proactive conversation or very vigorous defense works for the United States. University of Michigan is really a pioneer in the disclosure, and what they have seen is shorter duration of an open claim, meaning it's a time from patient actually filing the lawsuit and the time patient is compensated or the case is closed. They have seen fewer legal expenses, so they don't have to pay attorneys to defend the cases that are not defendable. And they have seen reduced compensations because they're proactive in saying, we're sorry that we made an error, we're willing to compensate for your injuries, this is what we offer. And patients oftentimes will take that compensation because they see a sincere approach, not just to disclose, but apologize and make things right for them. Implications of the disclosure, meaning what can happen as a result of disclosure, can be a significant barrier. And I think that's the last slide. So what I mean by that is the legal climate of the country may be a huge barrier. What happens in your country if you disclose an error to the patient, but there is no compensation? Patient has been injured. He or she will not be able to return to work that they have done prior to that event, and there is no compensation. Patient will go to court. And unless that's changed, unless there is another way for patients to be compensated, I don't see how you can have a successful disclosure program. So do you know who your elected officials are? Who you voted for the last election? They need to hear from you that it will be better for patients not to criminalize medical error, but work on patient compensation. Several countries actually have no-fault patient compensation, and if you ever go to New Zealand and get injured there as a tourist or as a citizen, you are entitled for compensation for your injuries. If you break a leg, for example, when you're surfing in New Zealand, you have to go to the physician, you have to file a claim. you'll get compensated. Doesn't matter if you're actually a citizen of New Zealand or just a tourist. It's no-fault compensation. Those schemes work in other countries as well, and Finland and Denmark, there are examples of those no-fault compensation schemes. It works a little bit different for some countries because the system has to prove that the patient would have had a different outcome if they would have been treated by a specialist as opposed to the physician that they were seeing. So it's the ideal treatment course as opposed to the actual treatment course. But at least the patient doesn't have to go through years of litigation. There was a case that was published fairly recently where a patient had a wrong testicle removed. Do you know how long it takes to close the claim and for the patient to actually get the compensation? Okay, let's think about it. Was there an error? Yes. Wrong body part surgery, very clear. You think the hospital would be actually proactive in offering compensation to the patient? No. So how long would it take? Let's see. 4, actually. Close. Excellent. But for the patient to go through 4 years of legal system to prove that there was an error, that's first. You have to prove that there was an error. And second, that that person is entitled to a compensation, that's a bit much. That case should have been compensated on the spot. All right. I'm happy to take questions.
Thank you, Dr. Melnick. It was a nice connection with Dr. Sargent's talk, who Dr. Sargent touched on analytical issues of medical errors from a high level, but here we're dealing with more micro level, more very complex issues and just patient interactions. So please, any questions?
Да, если я могу на русском, да, вам задать. Я тоже периодически экспертирую такие вещи и замечаю ошибки, которые врач вообще не воспринимает как его ошибка. То есть та самая шутка общеизвестная, чем отличается кардиохирург от Бога. Вы же знаете ее? Не знаете? Бог не знает, что он, не думает, что он кардиохирург. А кардиохирург думает, что он Бог. Получается, что специалист, он думает, что он не может ошибиться. И что надо делать для того, чтобы не то чтобы наказать доктора, а воспитательной целью, чтобы он в следующий раз не поступал так?
В таких случаях вопрос обычно, если вы можете остаться, вопрос обычно в чем была ошибка. Потому что ошибки бывают разного типа. Ошибки есть диагностические, когда проблема в том, какие данные мы видели и как мы этими данными оперировали. Или же это была ошибка, которая связана с нарушением протокола в лечении.
И экспертируя все вот эти вот летальные исходы и все ошибки, я понял, что в большинстве случаев, ну, скажем, процентов 70-75, это нарушение деонтологии этики. То есть человек не умеет разговаривать. Медиация.
Проблемы именно в коммуникации, проблемы именно в общении, наверное, одна из самых больших и самая большая причина большинства ошибок. Это может быть то, как мы разговариваем с пациентом, это может быть то, как мы разговариваем внутри команды, когда информация не идет от одного члена команды к другому. То есть это вопрос, где была проблема. То есть каждой ошибке обычно подход именно индивидуальный. Что случилось именно в том случае? То есть мы делаем...
Вот остальные, извините, 30%, это же ведь медицинская ошибка. И он не хочет признавать этой ошибки.
Дело в том, что в таких случаях это у нас заканчивается судом, к сожалению.
Ну а как сделать, чтобы он больше такого не делал? Чтобы он понимал свою ошибку. Человек не понимает свои ошибки.
Спасибо большое. Вопрос часто в том, человек не хочет или же понимать свою ошибку, то есть он не видит свои ошибки, или же человек не принимает эту ошибку как ошибку. В том случае, если человек не видит это как ошибку, то, возможно, в таких случаях дополнительное образование для врача, в том числе у нас это и курс медицинской этики, о том, что признается как ошибка, как нужно разговаривать с пациентом, плюс дополнительное обучение именно в тех темах, где он заблуждался. Тут уже нужна именно
я
статистика.
Понимаю, как наказать, чтобы он понял. Материально? Или же его все-таки условно дать какую-то условную статью?
У нас такого понятия нет. То есть статей криминального наказания у нас нет. Обычно это административное наказание. В том числе это дополнительное обучение, обычно идет как административное наказание, отстранение от работы на какое-то время. И чаще всего, учитывая образование наших врачей, врачи понимают, что они будут ошибаться, что рано или поздно эта ошибка произойдет. То есть это еще и работа не только с индивидуальным врачом, а работа со всеми врачами в стране о том, что если криминализация медицинской ошибки прописана в законах, то врачам будет очень тяжело свои ошибки воспринимать как ошибки. Это очень тяжело признать, что ты ошибался, очень тяжело сказать об этом пациенту, но в первую очередь нужно сказать об этом себе. Если нет соответствующего образования изначально, и мы с нашими студентами, медицинскими студентами работаем и говорим о том, что ошибка с вами случится. Это произойдет.
Thank you.
И мы говорим о том, как мы будем с этими ошибками работать дальше.
Thank you for your question. In the light of time, thank you. Maybe you could continue the discussion. No, but Dr. Sargent, please, your question.
Thank you for the privilege of listening to your talk. Thank you for mentioning also the second victim, which is very often forgotten. I'm an international auditor, so given by authorities from countries to audit organizations, hospitals, even care systems over large territories. And what I discover very often is system errors. I would like you to comment on two components. First of all, you put up the patient and the medical professional in a column, but in fact there is a third column, which is the hospital administration. And they play very often a very bad role in the management of the error. Yes, so that's the first component. And the second component is, I think the training, the medical training, is a catastrophe in the sense that we have not trained to work in systems and in a systematic fashion. If you look at the high-risk environments like the chemical industry and the airline industry who work with high-risk environments, cardiac surgery or even large hospitals, it is ridiculous the way they manage their systems and the absence of standardization. So I would like you to comment on that.
Oh, yes, absolutely. What I didn't mention is there are considered to be three victims of medical error. One is the patient, and that's the first victim when the damage is obvious. Second victim is the provider that was involved in the error. Third victim is the organization, because that's also harm potentially to the reputation. There are potential punitive effects and financial losses of the medical error to the system. And it's a question often how that third victim will behave, whether or not there is a place for the system to actually learn lessons. Do they see it as there is a lot more harm that's going to come to them as a result of medical error, or they see it as a lesson? Yes, there will be harm, but what will we learn as a system as a result of that error? Can we prevent that harm from coming to other patients and other patients so it doesn't happen to us again? And the organizational learning is a whole separate area, and unless that's in place, the patients will continue to suffer from same medical errors. Very recently, I would say in the last probably couple of decades, there are more and more analogies that are drawn between high-risk environments in other areas, which is actually nuclear power stations, aircraft carriers. They're very complex, they're very high risk. The difference between those two the medical system, which is also high complexity, high risk, and high complexity, high risk chemical industry, airline industry. When catastrophes happen to those industries, it's obvious. There's significant loss of life, there are significant injuries. For medical system, errors happen one at a time. So they're often hidden. When something happens to the aircraft and it goes down, we're talking about dozens and potentially hundreds of lives lost at one time. It's catastrophic. But we don't see a medical error and patient harm as catastrophic, and they should be considered catastrophic because they happen one at a time. So there is an error happen somewhere here, there is an error that happened in the cath lab, there is an error that happened on the floor, there is error that happened because patient was discharged with a wrong medication. We operate in silos, so there is a place here, a place here, a place there. We can have a serious patient safety event every 5 days, every 9 days, but most people in the system will not be aware of that. If something happens in other industries, everybody will be aware of that. There's communication across the system that we had this serious event, this is what you need to know, this is what we're doing about it. It does not happen to medical industry. So oftentimes the errors do happen and the loss of life and injuries are very significant if you look year by year, but most of my colleagues don't know how often our system actually experiences a significant safety event. We know what happened to us, we don't know what happened across the system. So there is no communication, and that's a big issue.
Thank you, Dr. Melnick, for your presentation.
Thank you.
I'd like to call our next speaker. Dr. Michael Furstenberg is going to talk about patient safety and team building in cardiac surgery. He's from the Summa Healthcare System in Ohio. Looks like we're missing Dr. Furstenberg, but if he shows up, we can fit him in a little bit later. Is Dr. Amash here? No? Nasser Amash? Okay. Okay, well, I guess that puts me up next, and we've got some extra time. Yes, please. We have extra time now.
You did not mention, Madame, I would like you to comment on the near miss and the reporting of the near miss.
Excellent question. Near misses is a situation, near miss is considered to be a situation where the system had a potential for harm, but that harm never reached the patient. And near misses are often not reported. I don't know what you have in your hospitals. Do you have a reporting system? I can rephrase it in Russian. В ваших системах есть структура, где вы можете сообщить об ошибке или же о ситуации, которая могла бы привести к ошибке? How often do you actually report? Can you raise your arm if you reported a near miss or an error in the last year? Okay. Yes. So near misses are often underreported, and there are multiple barriers to that. Often people don't think that it's reportable if the harm did not come to the patient, and they're afraid to speak up because the system issues need to be addressed. And some systems are really not pleased when they receive criticism from people who work there. And there is often not a closure for the person who's doing the reporting. So if you have reported something, did you report it anonymously, or you said that this is me and this is what I'm reporting? And did you hear back? I agree with one caveat. Anonymous reporting has been shown to improve reporting, not to deter reporting. And often, if you disclose who you are in the report, you need to be absolutely, if there is a perception that you have to be absolutely sure that there is a problem and you're not going to suffer consequences as a result of reporting. So volunteer reporting works in the systems that don't have a very strong safety culture. If you have strong safety culture, meaning you know that the system will take your concern seriously and will not take it personally and not go after you, then reporting with a disclosure of the name works really well. So often people do not report if there is no closure, if they don't hear back from the system that, yes, thank you for the report, first of all, and second, this is what we've done about it. It will unfortunately result in underreporting of near misses and underreporting of anything, to be exact. People don't want to report if they are afraid that the system will go after them, and that has happened in some systems. People don't want to report if they will not hear back. And some reporting systems are set up that it takes significant amount of time to actually file the report. So that's been shown as another barrier. If your system is too complicated to actually file the report, people will not take time to do it. It has to be very simple. I hope that answers the question. Our next speaker is Dr. Philip LaFleur. He actually works here in medical school with Nazarbayev University. Is that correct? He's been here for how many years, Dr. LaFleur?
6 years.
6 years. He will talk about clinical trial in Kazakhstan, opportunities and experiences. Seems like we're having technical difficulties, and I'm having language difficulties. Is Dr. Yu here? Yes? No? Dr. Rizzo? Oh, I think we may have to go to your talk. I hope you're prepared. Okay, so our next speaker will be Dr. Rizzo, who is from, where are you from? UK, United Kingdom. And she is talking about individual surgeon experience in adjusted survival rates in cardiac surgery. Dr. Surgeon should have stayed here for your talk. Please welcome Dr. Rizzo.
So hi, I'm Victoria. I'm one of the cardiothoracic trainees in the UK, and this presentation is about risk-adjusted survival rates in cardiothoracic surgery as compared to surgeon experience. also need a presentation. We just, okay, great. Okay, so first of all, I'd like to thank the chair and the WSCTS for giving me the opportunity to present today. I've given you a bit of a heads up here about, so we really looked at individual surgeons and their experience and how experienced they are as compared to their risk-adjusted survival rates and if there was any improvement. Oh. What goes next? Okay. So yeah, so next slide. So the background really is there are a number of studies which have showed improvements in survival rates with increased hospital volume, but there are less studies which show improvements with specific surgeons. So yeah, next. So this is just some literature. So this is a pediatric cardiac surgical study. This was published a few years ago, and this just showed that with increasing hospital volume, there were improved survival rates in pediatric cardiac surgical cases. This was especially shown with more complex procedures. And there's another study which showed just the hospital volume. Again, larger volumes, better results. And again, this looks specifically at the surgeon volume. So surgeons that had more than a number of cases per year had better operative mortality rates. Okay, so what we were really looking at was the risk-adjusted survival rate after cardiac surgery. And if this was affected, number one, by the hospital caseload, and number two, which we're looking into more, was the surgeon experience. So what we did is we went onto the SCTS website, which is the website for the United Kingdom, which shows all the cardiothoracic surgeons which are registered in the UK and their rates. So there you have an example of one of theirs, and you have all their the percentage of their procedures for every for those categories on the right-hand side. And then this was their second graph, which showed the number of procedures they did and their adjusted survival rate. To assess surgeon experience, what we did is we went onto the GMC website. Every registered consultant does have the date of their registration as a cardiothoracic consultant. So we took that and we estimated the amount of years they've been working as a consultant and then compared it to their numbers and the risk-adjusted survival rates. We also looked at the numbers per hospital in the United Kingdom. So in total there were 222 cardiothoracic surgeons which were registered, and there were a few that were excluded because there was no surgeon data or they didn't have GMC registration data. We also excluded the consultants that were working in congenital heart disease. So these were our numbers. So just to, we'll go through this slowly, but just so that you have an idea. So on the right, on the left-hand side, you have all the procedures, so the CAVGs, the other procedures, which are usually aortic work, AVRs, MVRs, and MMVR and CAVG, AVR and CAVG. And then we have all the columns. So in the first column, we have all those consultants which have been practicing for less than 5 years after registration. So those are the low experienced consultants. Then those which are 5 to 10 years post-registrations, which fall into the middle category. And then all those consultants which have been registered for more than 10 years, which we took as a high experience group. Okay? So going through them one by one, we did find that there was a difference in their case mix. So perhaps this is intuitive that, for example, in CAVG procedures, there would be a lot less CAVGs done by more experienced surgeons, whereas the junior or newer consultants would do a lot more of those. And then if we go on, we can see that's the truism. So, okay. The inverse is true for other procedures. So the more complex procedures, there would be more of those done by the more senior consultants as compared to the junior consultants. So you can see the trend along the way. So with AVRs, there were more done by more senior consultants, MVRs as well. And it's just a probable expected find that the less experienced surgeons would do more CAVGs, whereas the more complex procedures are done by the more senior consultants. However, when you keep going, again, to the bottom. Again, so when we looked at the risk-adjusted survival rates, what we did find is that there was actually no significant difference. So although there was a difference in the case mix of all the consultants, there was no actual difference in the risk-adjusted survival rates if you were 5 years post-registration or more than 10 years post-registration. So then we also looked at the number of cases per surgeon. So we took the median number of 400 cases. So when we split the surgeons into surgeons which performed less than 400 cases and those that performed more than 400 cases. And you can see that there wasn't actually any difference between that. It could be that the sample wasn't large enough for that, but this is what we found. And then we took all the hospitals. So we took again another median number of 1,500 cases. That was the middle number of cases per hospital. 18 hospitals had more than that, and 17 hospitals had less than that. Here we did sort of match with other studies where there was a difference. Obviously, the ones which had more cases did have better outcomes than the ones that had less cases. So in conclusion, really, we saw that there was a change in case mix. So we saw that more experienced consultants did have more complex procedures, and then there was no change in the risk-adjusted survival rate. Obviously, that could be affected by the fact that they were doing more complex procedures. Furthermore, there is, again, as matched by other studies, hospitals with larger volume do have better outcomes than those with smaller volume, and that's why we've sort of moved into a tertiary, sort of moving centers into cardiac centers, moving all the operations into bigger centers. And that's me. Do you have any questions? Thank you.
I have a quick question.
Yes.
First of all, I feel better referring my patients to the surgeon who's been out of training fairly recently as opposed to less experienced looking at that data. But I would also try to refer to a hospital, obviously, that has greater caseload. Could you speculate about the reasons why hospitals that see more patients and more cases have better outcomes?
So there were a number of studies which did look at that, and they were trying to identify, okay, so what is it that makes bigger hospitals have better outcomes? It's a number of things. So here we're looking specifically at the surgeon, but obviously the surgeon is only one part of a process. One of the biggest things which affects outcome, especially in bigger hospitals, is the fact that the whole team is used to caring for patients who are post-cardiac surgery. So especially in the pediatric cardiac cases, it was found that it's more the post-operative management and picking up problems quickly and the way they're managed after surgery, which also affects their post-operative outcome, and obviously not just the surgeon. So it's very hard to identify what's causing the problem. There was also a study which looked at the anesthetists. The anesthetists were not found to have any really factor on patient mortality. But the team, the hospital, the team, the post-operative team, and the team during surgery and after surgery, have a big factor and a big effect on patient mortality as well.
Thank you very much.
Thank you.
Other questions? Okay, thank you so much. We're going to try Dr. LaFleur's presentation. Do we have the slides?
So this is not strictly a scientific presentation, but it's a part reflection, part history, and I want to stimulate more discussion on this topic. I've been talking about this topic to several groups and working in this area for several years in Kazakhstan, and so I'd be interested in ideas and some discussion, I hope, after the presentation today. Next slide. This is our medical school, which you may have seen if you have been in the city at all. It's right behind the Cardiac Surgery Center. Next slide. So I want to talk about industry-sponsored clinical trials and Central Asia, specifically Kazakhstan today. Kazakhstan has This is sort of the representative of, in broad strokes, of the healthcare system in Kazakhstan. About 1,000 hospitals, 60,000 practicing physicians. Most institutions are state-owned. There is a health insurance scheme that's being developed, and there is some basic coverage for residents of Kazakhstan already. The pharmaceutical market is thought to be at least $1 billion per year. 40% of that is purchased by the state and about 60% purchased privately. And most major pharmaceutical companies are represented here in Kazakhstan. Next slide. When we think about pharmaceutical company industry-sponsored clinical trials, as you are likely aware, there are a number of factors that companies will consider when deciding where to do their studies. This is an attempt to think about different countries in terms of their attractiveness as sites for clinical research. So we think about, whoops, previous slide. There. We can think about things like how many patients do you have and how quickly can you recruit them? Can you do the study for a reasonable cost? What does it cost to pay a physician, to pay a hospital, to use its facilities for a clinical study? Are the regulatory conditions good? Can you get the study approved quickly through an ethics committee and through the regulatory authority? Do you have the relevant expertise? And do you have a good infrastructure? Do you have good equipment and laboratories with which to perform the clinical study? Next slide. There are thought to be many thousand clinical sites in the surrounding countries. We have China, India, Russia, and Brazil. Next slide. And in terms of the top 10 clinical trial indications, it's thought that cancer, diabetes, and infectious disease currently dominate the clinical trial, industry-sponsored clinical trial world at the moment. Next slide. This is an example of the potential revenues that are seen in a neighboring country in clinical trials expected to exceed $1 billion per year. Next slide. This is the slide I want to focus on. Stop here and look at it for a minute, because this represents the number of industry-sponsored clinical trials that are ongoing right now in the region. So for comparison, Canada, where I come from, has about 2,000 clinical trials, industry-sponsored, active today. In the US, there are about 8,000, and there's about 20,000 in the world. We have almost 1,000 in Russia. Ukraine over here is over 400. Belarus has a little under 100, and so does, I think that's Georgia down there on the left. Now, the mystery is why are there only 15 trials going on in Kazakhstan, which has inherited largely a similar system to Russia in terms of medical infrastructure and training of physicians? What is it that is preventing industry from deciding to do their trials in Kazakhstan? And so I want us to think about that a little bit today and think about the opportunity that could be in this field in Kazakhstan. Next slide. Just to give you an idea of some of the current trial sponsors here, they're very few, of course, because there's only 15 studies, but this is a list of some of the pharma companies that are currently doing trials in Kazakhstan. Next slide. We have a few drug and device studies ongoing right now. Many of you would have known that the HeartMate 3 program was happening here and is still happening here on an open label long-term observational basis. There's been some stent studies in Kazakhstan. There is a hepatitis study ongoing and a few other studies, but a very limited list of clinical trials that are ongoing right now. Next slide. So this is a list, this is a summary of the number of clinical trials that have been approved in Kazakhstan by the Ministry of Health. And I'd like to see that going the other direction. I'd like to see these numbers much larger. I think there's an opportunity that is being missed here in Kazakhstan. Next slide. So these are some of my observations just in working in this field over the last few years. I admit there's some judgment being applied here, and I'm happy to hear others' experiences if you feel this doesn't reflect the current situation. Next. I believe that there is an adequate patient pool in many centers, in particular in Astana, which is a center that, in which there are hospitals that collect patients from the outlying areas. Next. Sites can put together a reasonably cost-effective budget, including labor and facilities, with a reasonable amount of overhead. There are English-speaking, well-trained doctors in some centers, nurses and study coordinators. Now, the biggest sticking point in my view is the regulatory and ethics review time and in terms of transparency. Just want to pause on that moment for a minute in case there's anyone from the Ministry of Health here or industry. But we know that this is a major barrier in Kazakhstan, in my opinion. We need to move towards a system that's transparent, that a pharmaceutical company could go to a website and see very clearly what the targets are for review times, what the targets are in terms of the ethics review, and there needs to be a guarantee of a review time. Most countries that are progressive in this area have guarantees. For example, in Canada, if you submit a clinical trial application and you do not hear back from the regulatory agency in 30 days, you can start your study. So there's ways that Kazakhstan could put their best foot forward in this regard. There are ethical protections in place in Kazakhstan. There is a national ethics committee. As many of you will be aware, there are local ethics committees, and so that's developed over the past 10 or 15 years. We do have modern medical facilities and equipment, and we've experienced a fair degree of political stability in this country. So I think there are some positives, but of course this one factor here really needs to be improved in Kazakhstan in order to make clinical trials attractive on a large scale. Next slide. Just want to give an example of what I perceive as a fairly successful collaboration here. As I mentioned, the HeartMate 3 study, Dr. Pia and his colleagues performed this study at the National Center for Cardiac Surgery, which has about 150 physicians on staff, and they do 1,700 open heart surgeries a year. They do 600 PCIs. There's 4 cath labs, and they carry around over 4,000 procedures in the cath labs every year. So it's a fairly high volume center. And next slide. I want to just in a sort of unashamed promotional sort of way give some of the feedback that the sponsor of the clinical trial, St. Jude Thoratec, had about the site. It was quite positive overall. They commented that the study team was collaborative and professional. There was a dedicated English-speaking study coordinator. They were very content with the facilities. In fact, they even, this is just a quote, this is a direct quote from the manufacturer. They said that the facilities were superior for the study conduct and included the necessary laboratory assessments, diagnostics, and the standard operating procedures. The regulatory process, there was some lack of clarity around that, but their comment was once the process was established and understood, it was a manageable process. And in their case, they did receive a fairly favorable review time of less than 3 months. I have to say that that is not the case with some manufacturers, but in this case, it was quite a quick review time. And there was periodic reporting requirements to the regulatory entities, which were a little more intensive than they had in other countries. So perhaps that's a comment on the negative side. Next slide. The enrollment was good. The study met the enrollment target, and the expectations were met there. So the company was happy with that. There was a good patient selection. They were happy with how the outcomes were reported. The study compliance in terms of the investigators following the protocol was decent, was good according to the sponsor, and the data collection was done thoroughly, and there was a quick responsiveness to queries. So I'm throwing these things out just to give you a sense of what industry is looking for when they're thinking about evaluating their sites, because selection of sites is purely done on a business basis. There's 2 aspects to clinical research. There's the scientific and medical aspect, but choosing where to do their site, it's just a competitive decision. How can they do this site efficiently and get the results that they want? So we need to think, I think, shrewdly when we're thinking about promoting Kazakhstan as a site, as a destination for clinical research, but we need to also understand that it's purely a business decision at the front end. There was good support from a CRO, which was English-speaking here as well. Next slide. Just a comment that there's been a couple of publications which you may have seen from our colleagues at the Cardiac Center. So there are people here who are motivated to publish their research results as well. Next slide. And again, this is the University Medical Center, which is affiliated with our university, Nazarbayev University. Nazarbayev University owns 4 hospitals. They are all, except for one, JCI accredited, and they represent about 1,000 beds. Next slide. There's a wide variety of inpatients in many therapeutic areas, which you can see listed here. Next slide. And we have outpatient clinics in virtually every specialty, 46 specialties. There's a day surgery center at the Republican Diagnostic Center. Okay, next slide. So, you know, back to the reality and thinking of ways that this can change. I mean, just on a population basis, if you compared this to Russia, you would anticipate this would be about 150, not 15. Next slide. Следующий. Is it locked up? Okay, I'll just keep going. There's a current proposal. I've been working a little bit with the Ministry of Health in terms of proposed changes for streamlining the clinical trial legislation in Kazakhstan. Right now, I'll give you some examples of the current changes that have been made and are awaiting approval. Even this month, we hope that they will be approved. So right now, the Ministry of Health needs to approve sites for clinical trials, and they want to eliminate that, and so that industry can select the site themselves, which is usually the case in most countries that have large volumes. There are 4 laws that govern clinical trials, and this is going to be wrapped into one law. There are no standards for National Ethics Committee review times or for regulatory approval. And the proposal is that the National Ethics Review will be 14 days guaranteed, which I think would be fantastic. Perhaps a little bit aggressive, but be wonderful and very attractive. And then the National Center for Expertise in Almaty, it's proposed that they would have less than a 30-day calendar day guaranteed review time. Right now, there's very little motivation for pharmaceutical companies based in Kazakhstan to do clinical trials. They are focused on sales and marketing, and we understand that reality, but there needs to be a high-level encouragement here in Kazakhstan for these companies to give back to Kazakhstan in terms of clinical research, which will benefit both patients and physicians and just make some really great connections to the international research community. So this is just a little bit more about the current proposals. The proposal includes a line that suggests that phase 4 studies will only need ethics review, and that regulatory review will only be required in these cases. So we're talking about new pharmaceuticals, changes in dose or indication, bioequivalent studies, and then some specifics here about medical devices. Okay, I'll stop there. Any questions or comments?
Thank you for your presentation. I do have a question because From what it seems currently, clinical sites need to be approved by the Ministry of Health. Is that correct?
Yes, I believe that's true in some other CIS countries as well, that the Ministry of Health actually has to approve the site based on several criteria.
So how many sites are approved for clinical trials in Kazakhstan?
It's less than 100. I don't know the exact number, but I recall it being less than 100 sites, yes.
Do you have statistics of how many of them actually participated in clinical trials?
Yeah, it would be quite low in terms of the overall proportion that have actually participated. That's correct.
Are there some centers that never participate in the clinical trial? Or they just do one?
I believe there are, and I don't fully understand the motivations for getting approved to be a clinical trial site if you haven't done one, but it may also reflect just the difficulty in attracting industry-sponsored trials, in that there may be sites that are motivated to do it, but then they find in the end it's harder than they first imagined to actually attract a specific trial to their site. We'd like to see that change.
Is it difficult to attract attention of the industry, or is it difficult for the industry to actually go through the approval process at a specific site? So is it relationship with the industry, or is it more local factors, like industry wants to do a study at a certain site, but they're having difficulties getting everything organized at that specific site?
Yeah, in my experience, the major bottleneck in this process is industry motivation. So I think you could find physicians in any hospital in Kazakhstan who would be happy to participate in industry-sponsored clinical trials, but the main barrier is getting industry to come here and do it. And I've seen some large pharmaceutical companies even come so far as to visit Kazakhstan, to see the hospitals in Astana, to meet the physicians, and then at the last minute pull out and decide not to do the study here, because it's a complex series of decisions that go on to make that call. But I believe that there can be, especially with high-level government support and strategy, this could happen in Kazakhstan to a greater degree. Where I come from in Canada, there's a recognition that trials are actually leaving Western countries and moving eastward. And the numbers in Canada in some fields are actually decreasing because it's cheaper to do these studies in countries like Kazakhstan. And so I think it's a good time to take advantage of that situation.
Thank you so much. And going through the list of speakers, is Dr. Furstenberg here? And Dr. Yu? I think we're done. Are there questions for speakers who are present here? We can open up the discussion. Okay, thank you so much for your attention, and thank you for coming to the session.